So first of all, first topic is to discuss flow diversion. So I will present my clinical experience with P64, P64MW, P64MW HPC, P48MW, and P48MW HPC. I think flow diverter is a very important tool in the armamentarium we have now to treat intracranial aneurysm. So I think it's really important to see what we can do with these devices now, and also to see which kind of technical evolution we will have in the next future and what it will change in our current clinical practice. So here are my disclosures. So just to say a few words about flow diversion. To start with, flow diversion is increasingly used in the endovascular management of intracranial aneurysm. Initial indication, as René said, are large and giant aneurysm, as well as recanalized aneurysm, which is a very good indication too. But we have now a progressive enlargement to small IC aneurysm, distal aneurysm, bifurcation aneurysm, singularly with the development of what we call baby flow diverter, which are, for example, P48 flow diverter. I just mentioned here that the use of flow diversion is still controversial in posterior circulation aneurysm, and to some extent in bifurcation aneurysm, even if I will show you a great number of cases with bifurcation aneurysm treated with flow diverter. So we have some limitation of flow diversion. Indeed, the main limitation in the clinical use of flow diversion is the need of dual antiplatelet therapy for several reasons: to prevent acute intrastent thrombosis, to prevent delayed intrastent thrombosis, to prevent perforators on side branch occlusion, to prevent distal emboli. So the idea some company and some engineers have now is how to avoid dual antiplatelet therapy by modifying the surface of the flow diverter to reduce platelet aggregation. And we have now 2 or 3 flow diverters available for that. So just to present you the Phenox flow diverters family. So you have several generations. The first one is a P64 detachable. Now you have a second generation, which is a P48 MW. MW means movable wire. I will show you what is the value of this. You have it for P48 and P64. And finally, you have the HPC version. And I will also explain what is HPC. Sorry. So the area of application regarding P48, P64. P48 is dedicated to distal vessel, MCA, ECOM, PCA, PICA, and P48 is dedicated to a larger vessel, ICA, basilar artery singularly. So the first version of the P64 was a detachable flow diverter. You see the deployment of the flow diverter. It was possible to fully deploy the flow diverter, not 90%, not 85%, not 95%, but fully deployed 100%. But you see that it is attached to the pusher. So you can, I don't know if you see my arrow, but you see here, it is attached to the flow diverter. And when you are happy with the position, you can detach it, and it is a final situation. In parallel to that, Phenox was developing what they call MW, movable inner distal wire, which is the fact that the guide wire you have inside the flow diverter can be moved independently from the flow diverter. So if the guide wire is too distal with a risk of perforation, artery perforation, you can remove it. And if you need a big support, you can push it. So it's a very useful tool in my mind. Now, what is HPC? HPC is hydrophilic polymer coating. It is a coating which is placed on the flow diverter. It is a glycocalyx-like coating, which inhibits platelet aggregation different biomaterials. And by doing so, it is supposed to prevent thromboembolic events as summarized before. So we have, it's a comparison of the different devices, but I will go very rapidly just to mention that with the new version, with the MW version of the P64, the MW version of the P48, and also with the HPC version of this flow diverter, you can place them through 21 microcatheter, which is indeed quite important. So just to show you a case example, as indeed it's an unruptured IC aneurysm, a large one. You see that in that case, what we were doing is we were placing some coils in the aneurysm. Then we were deploying a flow diverter in front of the aneurysm, a 3.5 by 18. It's before detachment. After detachment, you see the flow diverter here, and it's after coiling. You see the final results. You see the control angiogram at the end of the procedure, and you see the control angiogram at 6 months, 12 months, with a completely stable occlusion, which you can probably not obtain. And I disagree a little bit with René on that point, that you can probably not obtain with a stent. Now, some example with the P48 MW. You see, it's an unruptured ECOM in a male of 51 years old. It's a relatively large aneurysm, irregular aneurysm. So in that case, what we were doing is we were placing some coils in the aneurysm, and to prevent any recanalization, we were deploying a P48 MW in front of the neck. 3 by 12, and you see that we are not completely happy here because we have maybe a cirrhosis. So what we are doing, we were ballooning inside the flow diverter. It's the final results. Probably there is something here, a kind of stenosis at the level of the neck, because you see that we still have something at this level, but everything was okay. It is the end of the procedure. You still have some flow at the level of the neck, and it's a 6 months control DSA showing a complete aneurysm occlusion. Now, an example with the P64 MW HPC. You see that it's ruptured ICA. It was treated with a thread in 2015. It was treated with a 4 by 5, probably by 15. And you know that finally we still have an aneurysm remnant in 2020. So what we were doing, we were placing a second flow diverter, which is a P64 MW HPC 5 by 18. And you see, we see that very clearly. You see the thread here, you see the P64 here, and you see it clearly also on the vasosity with the thread here on the P64. Here is the final control angiogram. We still have the aneurysm, and we are waiting now for the control angiogram. It is what we always do after aneurysm treatment by endovascular means. We do a MRI at 24 hours with DWI to see if we have some thromboembolic event, and you see that here we have a very limited thromboembolic event with very few spots. Now an example with a P48 MW HPC. It's a male, 26-year-old. He was treated in 2010 for ruptured ECOM. You see the treatment, it was not too bad. But in 2019, we have a large recurrence in aneurysm recurrences. Now, what we do, as soon as we can, we place some coils in the aneurysm sac, and we add a flow diverter to prevent a new recanalization. So it's what we have done here. We have placed some coils in the aneurysm, and finally, flow diverter in the A1, A2 junction on the left side. So you see placement of the coil, you see the deployment of the flow diverter, P40M MW HPC 3 by 15. It is the final control angiogram at the end of the procedure. And you see here the DSA at 6 months showing a complete stable aneurysm occlusion, and the same thing at 12 months. Now, just to say a few words regarding the management of complication with flow diversion. Here, an example, it's again ECOM aneurysm, quite irregular, relatively large in male, 51-year-old. It's a fortuitous aneurysm. So what you see how irregular it is. So what we decided to do is to place some coils in the aneurysm and to add a flow diverter in the A1, A2 junction at the left side. So coiling, deployment of the flow diverter. You see it's P48 MW 3/12. It is the final control angiogram. Everything is okay, but the wake up was okay, but 2 hours after wake up, what we had is right hemiplegia and aphasia. So what we are doing is MRI showing this spot in the frontal area and showing also that we have a problem with A2 segment on the, you see it here on the left side. So what we are doing, we are bringing back the patient in the angio suite. We are doing DSAs showing this clot in the A2 segment. So we tried to aspirate, but we were not successful with a 3-max microcatheter, aspiration catheter. So what we are doing, we are ballooning inside the flow diverter, and it was giving us the opportunity to fully reopen the flow diverter. And you see that the final control angiogram is completely okay. It is MRI at 24 hours showing the same lesion. You see that now the A2 segment on the left side is open, and MRS at 1 month was 0. And you see here the control angiogram showing complete aneurysm occlusion. Here another example, I do some mistake here. So the reason why I show you this case, it's a P2, P3 aneurysm with a wide neck. So what we decided to do is to place a flow diverter in front of the neck in the P2, P3 segment of the left side. So we do that. You see that because we wanted to protect the distal branch of the P3 segments, we place it asymmetrical, but it was not a good idea. It is DWI, MRI the day after, not too much to say, except that now you see that the flow diverter is not in the P2, P3 segment, but the distal end of the flow diverter is in the aneurysm. You see it also in the CTA perfectly. So what we decide, we had 2 options at that moment: to remove the flow diverter or to place another one to change the position of the distal end. So we decided to place the second one. So it is control angiogram at the beginning. You see the aneurysm the flow diverter is completely open in the aneurysm. So we were able to go through the first flow diverter and to replace it distally in the P3 segment. We were deploying a second flow diverter. I was a little bit afraid of the junction here, so I placed a third one. And it is a final construct on the vasosity. It's okay. It is, but 15 days after the procedure, we had paresthesia on the right side, and we were doing MRI showing this ischemic lesion in the PCA territory, and there was an occlusion of the P2, P3 segment, but I think it was an error to put 3 flow diverter in the P2, P3 segment, which is not so large. So it's a reason why we had this ischemic lesion. By the way, the patient is doing well, but still, I think it's a mistake. So, you know that there was a large P64 diversion study, and to my best knowledge, some of you were participating to this study. So the results are, publication is under preparation. So the idea was to evaluate the P64, the first version, detachable version. So there was 2 independent follow-up, one at 3-6 months, one at 7-12 months. It is a study committee. You see that the PI was Professor Alain Bonafé in France. There were a core lab, indeed, a CSC with all these very well-known guys. The evaluation at 6-12 months was effectiveness, rate of complete aneurysm occlusion, and the safety, which was evaluated by major stroke or neurological death. After the treatment of the target aneurysm, there were a lot of secondary endpoints. So there, 460 patients were screened, and finally 450 ITT patients were included, and 420 per protocol patients were analyzed. So, and we have, as you see, a first follow-up at a mean of 145 days and a second follow-up at 380 days. So when we look on it here, you see the centers who were involved in this study. At 12 months, you see that 472 P64 devices were implanted in 450 patients. The safety, you see that the major stroke and neurological death was observed in 2.5%. There was no delayed aneurysm rupture. So efficacy, again, at 12 months, you see that complete occlusion is 83%, which is a relatively good result, because you know that usually what you have with flow diverters at 12 months is between 70 to 80 or 85%. So it is a very good result. And what we see is that this study was showing in the very large population, it's the largest study dedicated to flow diverter, showing that P64 is safe and effective for aneurysm treatment. So we can compare this to other study, but indeed to save time, I will skip this and I will go directly to the conclusion. You see that the Phenox flow diverter family is illustrating the numerous rapid improvement that we have regarding the technology of flow diverter with different detachment system, movable inner wire, HPC coating. You see that the results of the P64 diversion evaluating the first generation is showing a very high safety and efficacy of P64. On evaluation of new flow diverter generation is underway. Thank you for your attention.